I am Shivan Sarna. I'm the founder of Chronic Condition Rescue because I had so much stuff wrong with me back in the day. I'm doing great now. And I've taught people and brought people together about the following topics: biological dentistry, the liver and gallbladder, the lymph, the fascia, menopause, IBS, SIBO, and a ton of stuff in between. And I'm the author of a book called Healing SIBO. I was exposed to mold for over 20 years in a work building, which I was then, once figured out what it was still in denial. Had a nasal swab done. There was MRSA in there. I still was like, just no, because what was I going to do? Quit my job? Anyway, I ended up retiring from that position at the TV station and helped another woman landed her dream job. And I was so excited for her as I continued with this particular mission. And during this whole mission, one of my biggest partners has been Microbiome Labs. Kiran Krishna and I are friends. He's the co-founder, and they are the creators of Megaspore and a bunch of other, I'm not going to say a lot because it's not a lot, but it's very specialized, curated formulations. They have blessed us in my community with doing monthly webinars, educational webinars for the past couple of years now. And today we have a very special guest, Alicia Galvin, who is not only a registered dietitian, but she also is an educator for other practitioners and certainly patients. And she is the new, we have an announcement, head of scientific affairs for Microbiome Labs. So she's super VIP. You're VIP, baby. And I'm so glad you're here. Thank you so much. We also have a different announcement. That's the most important one. But the Serene Skin, which you may have seen Alicia do a webinar on, I think a couple of months ago now, we didn't know when we were doing that webinar that it was like, we were just rocking it. It's reformulated. We're so excited. Wah, wah, it's out of stock. Like it had not hit the shelves yet. It is now there. So if you went to that webinar and you're like, when's it happening? It is now available. And we are going to send an email out to everybody with that replay because there was this like sort of, speed bump about it. So you'll be seeing that. Today, we are speaking about calcium. We are speaking about your bones. We're speaking about K2 and the shuttle that it is for making sure that your calcium, et cetera, gets into the right spot. I'm going to hand things over to you, Alicia. It's good to have you here. And I'm looking forward to seeing what you do next in your new role as head of scientific affairs. Very official. Thank you very much.
It is. It's very exciting. And thank you very much. I've actually really loved and enjoyed doing these webinars with you and your audience. I think it's such a wonderful thing that you offer to educate and just basically perpetuate the mission that we have in terms of the gut and the microbiome and all of the wonderful scientific and educational topics that we discuss. So as Shivan mentioned, we're going to be talking about the synergy of vitamin D and K2 in cardiometabolic health, and really talking through how these two work together and how they interact with calcium and the role that they play in our overall health. So this is what we'll talk about. We'll just do a State of the Union briefly on cardiometabolic disorders, the role that these two nutrients play, and then how they synergize with each other in cardiometabolic health. And watch for stars. I have a few slides that have stars on them. Those are just slides that you may want to pay attention to because they drive home some key concepts. And if you're a practitioner listening today, they may help you when you're speaking to your clients about this topic. All right, so what are cardiometabolic conditions? It's basically a cluster of these often preventable conditions that have both a cardiovascular and a metabolic factor. So things like stroke, diabetes, heart disease, and non-alcoholic fatty liver are all going to fall into this cardiometabolic category. And in the United States, no surprise, 1 in 3 adults have metabolic syndrome, which equates to almost 120 million people, about a third of the population. And this statistic is only growing. I think this is something we're all aware of, or we've at least heard about at some capacity. So it's a problem. Maybe you're dealing with it yourself. If you're a practitioner, maybe you are working with this group, or you're having people coming into your functional practice dealing with this condition. You probably are, because a third of us are. So it's an issue. And vitamin D and K2 play a big role in some of these things. So these are the different risk factors: high blood pressure, high cholesterol, high triglyceride levels, smoking, physical inactivity, having a diagnosis or the risk factors for diabetes or pre-diabetes, being overweight, not sleeping well. It's very important. Unmanaged stress is a big one, excessive alcohol intake, and then of course our diet play a big role. So as you can see, a lot of these are modifiable. There are some non-modifiable risk factors like our genetics, which we can't really do anything about, but the vast majority are things that we can control. So let's talk about the two all-stars, vitamin D3 and K2. So just as a quick review of what vitamin D is, it is a fat-soluble vitamin, but it's also a hormone. So it attaches to receptors in our various tissues and it signals. So it's a signaling molecule, which is why it's classified as a hormone. And then also just the chemical structure of vitamin D is very similar to our steroid hormones like estrogen and progesterone. We mostly get it from the sun, but some foods, depending on what you're consuming, can make up a smaller percentage, about 20%, and then supplements, of course, as needed per your vitamin D levels. Now, vitamin D, there has to be a couple of conversions that happen in the body that are reliant on the liver and the kidneys. So the liver is the first step that it converts this vitamin D that we're getting from the sun into calcidiol, which is the main vitamin D metabolite that is circulating. But then that has to be converted in the kidney to the biologically active form, which is calcitriol. So we have to have proper functioning liver, proper functioning kidneys in order to get to that end product that is what will exert all of the biological functions that vitamin D does. And it's a lot. 36 different of cell types in our various tissues are capable of using vitamin D and need vitamin D to carry out their different functions. So as you can see, anything from our vascular health to our immune system to our heart, our bones, our intestines, our pancreas, there's vitamin D pretty much touches just about every tissue that we have. Now, what would cause low levels of vitamin D? It could be decreased intake or decreased absorption, especially if there are any, digestive or malabsorptive syndromes. If you're not getting enough sun exposure, so the recommendation is that you're getting at least 20 minutes of sun plus times 40% of your skin being exposed, which if you're like most of us working indoors all day, we may not be getting that sun exposure. But also, where do you live? So as you can see on the right-hand side, there's this 37th parallel that if you're living above that, which is basically half the United States, you are not going to be, the sun and the earth are not at the right angle for those UV rays to penetrate through the atmosphere and actually exert the manufacture of vitamin D from the skin, especially in the fall and winter months for sure. So if you are living north of basically Oklahoma, you are at an increased risk of having vitamin D deficiencies. Of course, as we mentioned, there's conversion that has to happen in the liver and kidney. So if there's liver kidney disease present, you may have some issues with that activation. Age or skin is less able to convert and to produce vitamin D as we age. And then same with darker skin. There's a harder time with that conversion if there's higher pigmentation. Certain genetic mutations can make for like the vitamin D receptor or the CYP2R1. If you have these genetic mutations, it can affect how well your vitamin D can actually attach to those receptors and also be converted to the active levels. And then if you are overweight or obese, there's actually about anywhere between 8 up to 20 nanomoles lower levels of vitamin D than normal weight individuals. And this requires anywhere between about 1.5 to 2.5 higher supplementation. And that's because vitamin D is fat soluble. So if you have more fat tissue or adipose tissue, it sequesters the vitamin D. So you actually are at a higher risk of having lower vitamin D levels and you need more supplementation to get to the optimal serum levels. So this is just a snapshot of what you may want to consider if this applies to you or to any of your patients. All right, so what's considered deficient? The funny thing about this is there is no agreement around what is considered deficient. And so I'm going to tell you the story of vitamin D's journey as it relates to this. So back in 2010, the Institute of Medicine stated and released a report saying that vitamin D sufficiency was 20 nanograms per mil. Well, then a year later, the Endocrine Society released a report that said it's 30 nanograms per milliliter. And so the Institute of Medicine then responded the year after that saying, no, we actually disagree with this. We disagree because we don't see that there is a benefit of going to 30 versus 20. We don't feel that people are truly deficient or exerting deficiency symptoms if they're less than that. And they also disagreed with the at-risk populations. So then you fast forward almost 10 years later, and the Endocrine Society now no longer endorses any particular level or defines any level for vitamin D sufficiency, insufficiency, or deficiency. So now they did away with all of those criteria that they had originally set. And so now we have the Institute of Medicine, which is now the National Academy of Medicine, they are holding true to that 20 nanograms per mil, which is what most vitamin D levels are, what you're typically going to be seeing from your doctor, which is quite low, and we'll talk about that here in a minute. So case in point, there's really no consensus, and there's been some debate around this for years. So this is how it stands now with the National Academy of Medicine, that deficiency is defined at less than 12, insufficiency less than 20, and then sufficiency between 20 to 50. Well, if you use those definitions, 24%, so about a quarter of the US is deficient. About 37% of those Canadians that we were mentioning earlier are going to be deficient. And then if you're in Europe, about 40%, which this corresponds with the increasing latitude north. So the further the north you are, the higher the likelihood of there being a population that has more deficiency per this definition. Now, I think if you're a functional medicine practitioner, or if you are a patient seeing a functional medicine practitioner, more than likely you want these levels much higher than 20, probably higher than 50. And so there's probably, these numbers are probably on the low end in terms of, how many people are walking around with potentially some suboptimal vitamin D levels. So the recommended intake in the United States, which is the RDA, which is defined as how much does somebody need to take that's going to meet the requirement of 97.5% of healthy people. So this is taking into account they're not older, they're not at risk, they're not obese, these are just healthy people. And so that has, based on your age, it's up to 12 months, 400 IU, 600 IU for the most of the population up until 70 years old. And then once you reach 70, that it goes up slightly to 800 IU. But again, you're probably taking more than this in your supplementation if you're supplementing with vitamin D. So I want to talk about how we came to these numbers and go back to 2014, which is there was this group that looked at how the Institute of Medicine originally came up with those recommendations. And the original recommendations came from a body of, I believe it was 10 different studies and 32 different dosing of vitamin D. And they did the statistical analysis, and that's how they came up with the 400 to 800 IU. But then this group, 4 years later, came to a different conclusion. And what they found was that the statistical analysis there was some errors around that. And that when you went back and you reanalyzed all the data, that 600 IU that's recommended for most of the population really only gets you to 10 nanograms per mil, not the 20 that the IOM is recommending. And that actually, in order to accomplish the RDA, which is that definition of 97.5% of healthy individuals, the dosage needs to be almost 9,000 IU of vitamin D to reach that, to the goal of that 20 nanograms. So it illustrates that, and there can be debate around this, but it illustrates that either way, the dose that is currently recommended is probably far too low, and that the actual dose that's needed is probably much higher than the current RDA of 600. This was another study done by a different group in 2017. And they go through and they talk about how some of the largest meta-analyses that were ever conducted on vitamin D showed that actually going above 30 or being less than 30 is associated with higher all-cause mortality. And that really, again, when we look at certain specific conditions like autoimmunity, metabolic syndrome, like we're talking about today, diabetes, cancer, that you can move more towards a relative risk of 1, which essentially means you're evening the playing field if you get to that 40 nanograms. And remember, the IOM recommends 20. at being considered sufficient. But again, for healthy individuals, that might be okay. But what about the vast majority of people who have some of these more targeted conditions? So it's no wonder that we're a vitamin D deficient nation, because we can't agree on the level that's considered deficient, and we can't agree on how much somebody should take. So no wonder that there's confusion around this. But there's another side of the story, and the other side of this story is vitamin K2. So when we think about vitamin D and K2, if you're a fan of Jerry Maguire and Tom Cruise, I think of it as you complete me as a scenario, because you really shouldn't take vitamin D without K2. Now, I want to do a little bit of a just setting the stage of the differences between K1 and K2, because this is a point of confusion for people. So K1 is made in plants and algae. It's tightly blended to chloroplasts, which think green. So these are your like green leafy vegetables that we talk about, your broccolis. But only about 10 to 20% of it is going to reach circulation. And this is what will affect your blood clotting. Now, K2 is made by bacteria, and it's very readily absorbed and distributed into the tissues. And there's two forms of K2. We have MK4, which is in your animal tissues like liver and brain. Grass-fed beef, butter, and eggs have a little bit of K2 in them. But the majority of where we get our K2 is from our bacteria in our gut, from our intestinal microbes. If you're in more Eastern cultures and you're eating natto, or if you're from Norway or the Nordic countries and you're eating some very specific fermented fish and cheese, then you might be getting some K2 from your diet. But most of us in the Western world are not going to be eating those things, and probably going to have to rely predominantly on our microbiome to make our K2. So this is the family tree. If we think about meat, vitamin K, and where everybody lives. So K1 and K2 are the two, the two different forms. But then within K2, we have even further differences. So we have the MK4, MK7, and then with MK7, there's two forms called cis and trans. Now, the reason this is important, I promise I will bring it back, is this is highly important because depending on the type of vitamin K2 that you are taking in your supplements, there are some questions that you want to ask the company or your provider to make sure that you're taking a vitamin K2 that is actually going to do the job that K2 is supposed to do in the body. And some of that relies on whether it's a MK4 or MK7, but also is it a cis or a trans form. So MK4, not as effective at raising vitamin K2 levels. It's less bioavailable, has a very short half-life. So you have to take a whole lot more MK4 than MK7 because it has a very short half-life. And so that's why you need the minimum dose is, anywhere between 400 to 500 micrograms. Now, MK7 is much more efficient at raising K2 levels. It's much more bioavailable, and it has a longer half-life. And so the minimal dose that you need for helping with the biological processes that K2 does is about 90. But there are some, for certain populations like postmenopausal women, 180 micrograms can actually be very beneficial in protecting the heart and heart function. And so it's what's actually preferred in the research. It's preferred over MK4 for supporting bone health and reducing arterial calcification. All right, let's talk about how it does its magic. So we have three proteins in our body: matrix GLA, osteocalcin, and Gas6. These are circulating and floating around in our body completely inactive. They're just tootling around, minding their own business, not doing really anything until we have what's vitamin K2 activates this enzyme, and only vitamin K2 activates this enzyme. And that enzyme carboxylase then changes these proteins to then make them active. So matrix GLA protein helps to pull calcium from our soft tissues. So it pulls it from the arteries to help to prevent that arterial calcification. Osteocalcin is what helps with laying calcium onto the bone to encourage bone formation. And then Gas6 has a role to play in neuroinflammation. So we have to have K2 in order to activate these proteins. Otherwise, they just float around minding their own business, not doing anything. And so we have to have adequate levels of K2 to do this. Now, what's the recommended intake for K2? Well, again, we don't have one. There's no DRI. And what we have is what's called adequate intake, which is a different type of measure that when there's not enough sufficient evidence to make an RDA for a certain nutrient, then it goes to an adequate intake. But there's no differentiation between whether it's K1 or K2. And as we talked about, K1 and K2 do totally different things. Vitamin K1 is not going to activate these proteins, K2 will. And so when we look at these recommendations of how much is needed for these different populations, it doesn't really classify or tease out one or the other. So if you see in the upper right-hand corner, there's an article that discusses how basically we need to have an RDI that is separate for K2 and separated from K1 because of how different they work in the body. Now, it's, as we mentioned, this whole conversation is just the importance of K2 in cardiovascular health. So even though we don't have a true DRI or an RDA, we just have an adequate intake, we know that there are very effective recommended dosages for cardiovascular health, and it ranges between 180 up to 360 micrograms a day. And it's dose dependent. So the higher the K2 level that you have, the more of these more activated matrix GLA proteins we have. So there's a dose dependency of we activate more of these MGPs, the higher the level we have. It's also very safe. It's very well tolerated. It does not cause a hypercoagulable state. There have been no documented cases of toxicity of MK7, and there is no upper tolerance level per the WHO. So it's a very safe nutrient. There are very high levels that have been tested to see if there's toxicity, and you'd have to get to millions of micrograms in order to reach that. Now, what causes K2 deficiency? Well, if we're overprescribing calcium, if we're supplementing vitamin D without K2, statin drugs also, if you look there on the right-hand side, you'll see that statins and the cascade that they intervene in order to prevent the production of cholesterol, but there's also a pathway that's part of it that helps with our body and our microbiome's way of making that K2, and it also gets inhibited. So if you're on a statin drug, you can have a risk of lowering your K2, which is helpful for cardiovascular health. So it's kind of this cycle that can happen. Dysbiosis, of course, if we're eating a lot of processed foods or antibiotics or food preservatives, that'll affect the microbiome and will affect K2 levels. All right, so let's talk about putting it together with the synergy of vitamin D and K2 and cardiometabolic health. Now, there's an interplay between these two nutrients, absolutely, as we've talked about. What's really interesting is that, vitamin D, what it does is it's really good at bringing calcium into the blood. So vitamin D enhances and increases our intestinal calcium absorption. So if you're taking high levels of vitamin D and you're not balancing it with K2, what you're doing is you're essentially pulling more and more of that calcium into the body and into circulation. Well, then calcium sort of floats around going, I don't know where to go. Where do I go? Oh, look, here's an artery. Here's a soft tissue. Let me deposit here. Because if there's not enough of that matrix GLA protein and osteocalcin to redirect and essentially usher that calcium of like, hey, here, let's come over here. Let's not go into the artery. Come to this seat of the bone. This is where you need to go. And so this is why things like taking vitamin D and calcium without K2 is going to potentially increase some of those risks of arterial calcification. So key takeaway is just always take vitamin K2 with vitamin D supplementation. Now, this is a little graphic. Feel free, you guys can get these slides later for Shivan. This is a nice little schematic that represents some of what we're talking about. So if I've just thrown a bunch of science at you and you're like, I don't know what she's talking about, this might help if you're more of a visual learner of where we're wanting calcium to go, which is the little kind of yellow circles. We want them to go onto the bone, away from the arteries. And this is sort of the second part that explains what's happening there. So what vitamin D also does is it stimulates our osteoblasts, which is our bone building cells, to produce inactive osteocalcin. So basically we get vitamin D in our body. The bones are like, oh, hey, let's make some bone. So it starts shooting out this osteocalcin. But remember, it's inactive. It's one of those proteins that just sort of floats around minding its own business. So if we don't have enough K2, as you can see, then we don't have the ability to activate it and then lay the calcium onto the bone. However, if we have enough K2, then we're going to be stimulating the osteoblasts to make this osteocalcin, and then we're going to be activating that osteocalcin to lay and glue that calcium onto the bone, which is what we want it to do. On the flip side, again, what happens is vitamin D stimulates matrix GLA protein inactive. If we don't have enough K2, it will stay inactive. And this is where those calcium little molecules can start to lay themselves into the tissues. However, if we have the K2, then it will activate that matrix GLA protein and it will redirect away from the arteries and lay that onto the bone. So there's a synergy here that's happening between these two nutrients. And it's a cycle, and it has to continue in order for us to keep that calcium in balance. So think of vitamin K2 as calcium's personal valet. It's ushering the calcium where it needs to go and helping to direct it to the right parking spot. Now, if you are familiar with, or if this has been an area that you've, sort of lived and breathed for a while, then you'll know that there was a study way back 2004 called the Rotterdam study. And this was the first, it was a massive study, included almost 8,000 subjects. And it was the first study to show from a diet intake standpoint that those who were consuming upper levels of vitamin K2 in their diet, but not K1, had a 50% lower risk of arterial calcification, about a 50% lower risk of cardiovascular death, and a 25% lower all-cause mortality. So this was a sort of a, what's going on here with the K2, but not the K1 in terms of cardiovascular health. And so since then, we've had many more studies that have explored this. And what we know now is that K2, specifically MK7, which remember is one of the arms of K2, improves arterial stiffness in healthy adults, postmenopausal women, patients with coronary artery disease, and renal transplant recipients. And it can also improve nitric oxide production, which is very important for our elasticity and for oxygenation and endothelial function within our arteries and vasculature. Now, vitamin D and heart health, because remember, vitamin D is super helpful, and a lot of us are deficient in it. But vitamin D deficiency also correlates with hypertension, type 2 diabetes, dyslipidemia. It's very anti-inflammatory. It helps to inhibit some of our pro-inflammatory molecules and promotes anti-inflammatory molecules like interleukin 10. And there is an association between vitamin D and atherosclerosis plaque development through immune modulation. So again, as we talked about at the very beginning of this presentation, there's a lot of confusion around vitamin D and what level do we need to be to prevent and be healthy. And we can't forget the vitamin D conversation either, because it plays a role in our heart and cardiovascular health. Now with insulin, since insulin is another component of cardiometabolic concerns, there was a 10-year study of almost 40,000 Dutch people between 20 and 70 that found that higher levels of K2 intake were associated with a 20% less likelihood of developing type 2 diabetes, and that the risk of type 2 diabetes dropped for every 10 microgram increase in K2 intake. So again, kind of similar to what we saw in the Rotterdam study, the highest intake of K2, which was about 250 to 360, had the lowest likelihood of then developing type 2 diabetes. And so there's this scenario of K2 being able to reduce that progression of insulin resistance and helping to increase insulin sensitivity. On the same lines with vitamin D, super essential for helping to regulate insulin and for tolerance to sugar loads and glucose tolerance. And so when vitamin D deficient individuals are supplemented with vitamin D, it tends to improve their insulin secretion and their glucose tolerance. So again, really important for those who are at risk for developing any type of blood sugar imbalances or have high fasting blood sugars, or if they're on the progression of insulin resistance, definitely want to be thinking about vitamin D as well as K2. So some optimized nutrient formulations. So MegaQuin K2+D3 is a combination of these two nutrients that we just talked about. So vitamin D, the dose is per 1 capsule, 5,000 IU. and then also a really nice hefty dose of vitamin K2 at 200 micrograms. And it is, we use one of our own proprietary ingredients, MegaQuin Gold, which is 100% of that MK7, and it's 100% natural. So but when we were talking about the cis and the trans forms of K2, what we want is the trans form, which is the natural form. We don't really know what cis vitamin K does. We don't have data that it's biologically active, and so different companies will have mixtures sometimes, like their K2 will be a mixture of natural and synthetic, which is a mixture of cis and trans. So what you're wanting when you're looking at a K2 product is it MK7? And then is it 100% or close to 100% natural? Our K2 is made from fermented chickpeas, not from soy. We're the only non-soy vitamin K2 that's on the market. Any of your other, even if it's a natural K2, it is more than likely fermented from soy. So that's what our product looks like. It's also the cholecalciferol form of D3, which is the biologically active form of vitamin D. It's ethically sourced from lanolin. The sheep are raised specifically for this purpose. They are very happy sheep. They are not slaughtered or raised for anything else other than the vitamin D from their wool. They are not harmed during the process of it. And it's microencapsulated, which is another way that we can ensure that it's very highly bioavailable. Now, again, the K2 is that 200 micrograms. It's very stable, highly bioavailable, and it's backed, this particular ingredient, by 23 research studies, ranging from cardiovascular studies to blood sugar to muscle aches and nerve issues. So there's a range that it's been studied in. And again, it's the trans isomer, so it's 100% natural. Now, safety is a big question mark for people around vitamin D supplementation, and the concern comes from that hypercalcemia that can happen. As we mentioned, vitamin D is really good at pulling in that absorption and enhancing that absorption of calcium into our system. And so if you are taking too much vitamin D and you're getting increasing levels of calcium in the serum, then that can lead to this hypercalcemia, which can have symptoms of nausea, vomiting, muscle weakness, etc. Now, typically that's associated when your vitamin D level starts to get above 150 nanograms, which is pretty high. But it can happen at lower dosages. So this is something where you just want to be very aware of what the symptoms are, especially if you're taking high dose vitamin D. Now, the IOM Food and Nutrition Board has established some upper levels for vitamin D, but they've also acknowledged that in the literature, there are very routinely dosages of about 10,000 IU that have been used very safely and without any type of adverse reaction. So the 10,000 IU level seems to be tolerated by most people. But again, this is very specific to different individuals because, again, like we mentioned, there's some different scenarios that can impact how that supplementation is going to actually translate to serum levels, whether they're obese or, depending on their absorptive capacity, that type of thing. So the generally recommended safe goal for vitamin D per the IOM is between 50 and 60. I know some providers like to go a little higher than that, closer to the 80 or so range. But again, you just have to kind of work with your provider on what's appropriate for you, and also just make sure if you're a clinician that you're monitoring your patients' vitamin D levels. So, but always take K2 with vitamin D to mitigate the effect of this even happening in the first place, because if you have enough K2, it'll redirect that calcium. Now, for vitamin K2, again, the toxicity studies that have been done, basically up to 20,000 milligrams, which is milligrams. We typically dose at micrograms. So, well below what that toxicity level would be. There was a study that was done in animals looking at does K2 affect clotting and warfarin. And again, they had to get to very, very high dosages, like 9 million micrograms in order to even start to have a hint of affecting the clotting. Now, I would say that if somebody is on a blood thinner, you definitely want to coordinate care. Just out of an abundance of caution, make sure that they're being monitored, looking at PT-INR, looking at their levels. Definitely if it's warfarin. Any of your other newer generation of blood thinners would say you still want to proceed with caution just to make sure. Make sure they're being closely monitored if you're going to initiate some vitamin K2. But in general, there shouldn't be much of an impact. But just again, proceed with caution to work with your provider on that. So just some key takeaways. K2 is calcium's personal valet. It's very critical for calcium balance. You always want to choose the natural form or the trans form of K2 with that enhanced bioavailability and definitely the MK7 form. And then the visual, like I said, you'll be getting these slides, and so you can take a look at this and show it to your provider. If your provider is trying to talk to you about some of this, refer to this as well if it helps to remind you what all these different words are meaning and what they're doing in the synergy between these two. So with that, I'd like to thank you and appreciate your time.
Thank you. That was fantastic. That was fantastic. Yeah. Seriously. What's your biggest takeaway, everybody? I'm going to open up the chat. And by the way, the slides are available if you've been watching live and you purchase by 8 p.m. Eastern time. That's an in-webinar purchase bonus. And I'll explain that in a second. Let me see. Attendees can chat with everyone. Okay. Yeah. What's your biggest takeaway from today? I think that the different forms is really interesting. And I don't think even though I've heard it before, it just really helps to clarify. And I appreciate you all working so hard at Microbiome Labs to make this available. So confusing. You go to not the osteopath, the orthopedist. They're not talking about this. They're just not. They are not talking about this. You go to your typical doctor, not talking about it. So I want to get into the questions, but I also just want to say that the link is in the chat to be able to order with the 15% off. And if you do order by 8 p.m. Eastern time tonight, just for those of you who are watching live, you will receive her slides and the masterclass from Kiran Krishnan, who is the co-founder of Microbiome Labs, who covers the same topic. It's interesting to hear it from different angles. And you do need to email us at the email I've put into that chat link, which is info@SIBO.SOS, with our links being used, proof of purchase by 8 p.m. tonight. Okay. I am going to go to the Q&A box because that's where the questions are. We have a lot of them. We have 20 minutes and we have 20 questions.
Okay.
Let's see. Okay. Somebody lost all the info on the links. You will get a replay tonight, and I'm reposting. Okay. There you go. Are you ready? I hope you took your vitamin K and have a lot of energy.
Fire away. Okay.
Could you get as much vitamin D equivalent from the sun without having to take a supplement?
Possibly, but it would depend on a lot of those factors that I mentioned as far as what causes, where do you live, what latitude, how much sun exposure do you have, how much skin is exposed, what age are you, what genetics do you have?
And you talked about that.
Pigmentation of the skin. So possibly, but you'd have to monitor levels and see if you are getting enough for that.
When you say liver or kidney disease, are you aware of those with the MTHFR C677T heterozygous and homozygous having more difficulties absorbing or converting vitamin D?
I don't know specifically on the research if there is that correlation. I would imagine, there's lots of issues that happen if you have those MTHFR mutations and the whole methylation pathway. More so referring to if somebody has like true kidney disease, like an issue with their kidney function, or like cirrhosis or fatty liver, or any of those types of conditions where it's truly going to affect the function of your liver. That's more what I was referring to in terms of affecting vitamin D activation. Yeah.
When one loses weight, does vitamin D sequestered release?
It can sometimes. So there's a few things. Another reason why, like with rapid weight loss. So I'm thinking anybody on any of the GLP-1s or, any of those types of things. There's many things that have to be factored in when you start to get into that rapid weight loss. Gallstone risk goes up, vitamin D levels, your estrogen levels and how that affects your vaginal microbiome and glycogen production. So there's many things that have to be factored in when you start to lose that fat quickly. So,
and if it does get released into the blood at the time, does the body uptake that vitamin D or does it get urinated and pooped out?
well, vitamin D is fat soluble. So, you're going to see some changes more so in the serum levels. And so you would just want to be monitoring your levels. I wouldn't say it would be urinated out. No.
Okay. For what reason is the gap between the Endocrine Society and the IOM thought is what they thought is healthy so wide between what functional medicine practitioners speak to? One would think that all medical practitioners and especially medical societies are followed the evidence base. No, I found that that is not what happens. Just FYI, I know that what you're saying is logical. In my experience and exposure to all of these doctors and organizations that I've been exposed to as an outsider looking in, as a consumer, I do not see consistently that people are following evidence-based. I know it's crazy, but I don't. What do you think?
Yeah. There's a challenge with vitamin D research, and that's part of why there's a discrepancy. Some of it is that there's not really a standard. There's a couple different ways that you can actually test for vitamin D, and without getting too much into like the technical pieces, there's your LCMS, which is your liquid chromatography mass spectrometry, which is what a lot of people use. That's much more efficient and accurate, but there's an alternative way, the ELISA way, that some in the research are used, but you can vary, the vitamin D levels could vary as much as like 20 points. And so the lack of the standardization of like what's being used in the research to label the vitamin D levels, again, supplementation dosage not being standardized. What are you labeling as deficient? There's like all these different things that haven't been standardized that makes looking at the body of research harder. So that can be part of where there's some discrepancies. And depending on the organization and what criteria it's using, that can lead to some issues.
Can I take megaquinone K2 and D3 and Serene Skin, which also has
Yes, it also has K2.
K2 M7, or is that too much K2 M7?
No, because the combination of those two would be, I believe, about 320 micrograms total, which is well within what's used in the research.
Okay. Ruth, hey Ruth, how you doing? Confusing. I thought K2 is more for the heart and MK4 was for the bones.
So newer research, MK4 is better for heart and bones. So
okay. Additional considerations when supplementing D and K for those taking any bone drugs, dose, type, time, separation from meds.
Yeah, so if you're taking any of those bone building medications, you would just want to coordinate care with your provider to make sure that levels are being monitored and vitamin D and there really isn't a great way to monitor K2 levels. There's not like a standardized lab that's available to commercially really. So it's mostly looking at your vitamin D levels, and K2 is just, it's very helpful. You don't have to worry as much with that.
Okay. Please put your questions in the Q&A box. We're not going to get to everybody. I can tell right now, because we're in, yeah. Okay. If one was supplementing with vitamin D without K vitamin for many years, how do we know what dose is appropriate? I've been taking avorstatin for over a couple of decades now and don't know if I need to take more of these. That is definitely a doctor question. You just said there's no way to test for K2, but there is a way to test for D.
Yeah. Yes. Yeah, I would. And again, the dosage of K2, I would say based on the literature and the research, if you can get around 200 to 300 micrograms of K2, and actually there's some newer research, and Dr. Mark Houston will be, I think, presenting on some of this, but even high doses of as high as like 700 micrograms of K2 for coronary calcification. So there's some data out there that is emerging of maybe even higher than that, but yeah, 200 to 300 should be fine.
Okay. Is it possible or probable that taking a fair amount of nanokinase supplement would provide K2 or K1? Are those powdered supplements typically the natto vegetable powder?
Nattokinase is an enzyme, so it wouldn't be like the natto. Yeah,
they're different.
Yeah, they're different.
They're different. They're different. Good question, though. I can see how that could be confusing. Which
Mm-hmm.
bacterial strains off of the gut microbiome analysis test seems to be most responsible for vitamin K activity production in the gut?
There's a lot. B. fragilis is one. Actually, B. subtilis, which is in our megaspore, is one. There are actually some pathogens, not pathogens, some opportunistic microbes like E. coli that can even make it. The list is long. It's more about your function of the whole microbiome. Our biome effects test looks at the function of K2 production, but yeah, there's a lot of different ones. But those are just a few names.
Okay. Okay. I've seen so many ratios of vitamin D to K2. What is the ideal ratio per your view? And do most functional medicine providers agree on the ratio you recommend from what you understand? Or does that ratio always hold true when dosing 10, 20, or 30 K vitamin D per day?
There is not a consensus.
Okay.
But I would say the one I usually go with is for every 1,000 IU of D, you take 45 micrograms of K. Some will say for every 1,000 you take 10, but I like to err on the higher side just because of all the wonderful things K2 does.
When the body receives a mushroom-based vitamin D versus a lichen vitamin D, does the one derived from sheep wool versus the one derived from the lanolin on sheep wool, how does the body make use of these differently in terms of actions on the bones and other organs?
So if you have vitamin D derived from mushroom, that's typically the ergocalciferol form, which is not as effective in helping vitamin D levels. When you look at lichen versus lanolin, which is lichen would be a vegan source of vitamin D versus the lanolin, but there's really not a huge difference between those two. But lanolin just tends to be what's more widely used, just it's more available. And but yes, we want to choose either lanolin or lichen, not mushroom-based ergocalciferol.
Okay, and how does their use work differently in terms of the bones and other organs?
Ergocalciferol is not as bioavailable. It doesn't work as well. Cholecalciferol, which is what we talked about today, is going to be much more bioavailable and user friendly for bone health.
Is a vitamin K2 test available anywhere?
No, not really. I mean, there's one functional medicine lab that I know of that I think offers one, but there's not really a validated way to test K2 now.
I understand Quest, LabCorp, and even functional test kits testing blood like SpectraCell. I don't know why, but none of them allow for testing vitamin K2. So how does one know your current vitamin K2 amount?
There is one test that you can get, and it's a matrix GLA protein, an uncarboxylated one. It's not widely commercially available, but when you really look into the research of like what do you use for K2 levels, that's the one that comes up, is that you look at an uncarboxylated because there's a dose dependency between K2 and those matrix GLA protein levels. But like I said, it's not super widely available to get commercially.
What's the name of that lab?
Uncarboxylated matrix GLA protein, which is basically your inactive matrix GLA.
And what's the name of the lab doing that test?
Oh, I'd have to go back and look. There's one when I was researching, I can't remember. But again, it's not commercially. If you were in research, you could probably access it, but
it's not available to the consumer. No. Okay. Bummer. Okay. All right. We have 9 minutes and 16 questions. We can do this. Hey, Kathleen. So is K2 safe for people with clotting disorders like SLE with antiphospholipid syndrome and on a lifetime of anticoagulants? So sorry.
So again, in theory, K2 doesn't affect clotting. However, you would want to coordinate care with your physician.
Okay. What if you are prescribed a calcium channel blocker for high blood pressure and high blood and liver pressures, higher dose of MK7 ? Hi, Ellen.
Yeah, I mean, I would say you definitely would want to be on K2 for that. Yeah, again, that 200 to 300 micrograms is typically what I go for.
If I get sun daily for my vitamin D, should I just add K2?
Sure. I mean, you can take K2 on its own. Its safety profile is great. So yeah.
In what ways does the fermented chickpeas compare in contrast to the natto or soy-based?
So in terms of, it's more about not necessarily the source of it's more about the type. Is it MK7 and is it natural, 100% natural? Just
Okay.
some people, if they're super sensitive to soy, they like to avoid soy-based
Yeah.
fermented K2s. And whereas chickpea, there's no soy at all in any of our facility at all.
Okay.
So
Okay. Recently I learned that there's a prescription drug that is vitamin D. How is that different than what people can buy from supplement companies?
some prescriptions use D2, which is again not what we want when it comes to, it doesn't elevate your D levels as well. So I don't know if that's what you're referring to, but there are some prescription D2 very high dose levels, but they're not ideal. And if you look at the more recent vitamin D research, again, they're pretty much all pointing to you want the D3, the
Okay.
cholecalciferol.
Okay. Wait, what is it? Wait, what is it that can occur at lower dosages below the 125 to 150 toxic zone? The symptom of being nauseous and vomiting or some deeper, worse things happening in one or more of our organs, even if we don't feel symptoms. For example, at 115 level?
I'm sorry. So they're asking the symptoms of how.
What is it that can occur at lower dosages below the 125 to 115 toxic zone? I'm not sure if I understand the question either.
Okay. So what I would say, I think I'm understanding, maybe correct me if I'm wrong, but so the hypocalcemia for different people you can start to experience those hypercalcemic symptoms at lower levels than what the cutoff is 100, which is
Got it.
150. Generally, most issues are going to come when you're above that 150 nanogram. But for some people, depending on your metabolism, sensitivity, all these different factors, you might experience some of those issues if you're supplementing with higher dose vitamin D, but your D level is below that 150. So again, you would want to work with your doctor, get your calcium levels, your vitamin D levels checked. If you'd want to coordinate with your provider on that because it could happen at lower dosages, but generally it's above that 150 nanogram dose.
Is the best test a 1,25D test?
No, you want a 25 hydroxy. The 125, while it is the active form, it has a very short half-life. So that's why the 2 hydroxy vitamin D is typically used and is considered the gold standard because it has a longer, like 2 to 3 week half-life. So
Okay.
you get a better read on what someone's levels might actually be.
For someone prone to osteoporosis, does the literature support calcium supplementation along with K2 and D3?
Yes, actually, I didn't present it, but there are studies done on like hip fractures and bone fractures that when you combine vitamin D and K2 with calcium, you actually get a better rate of helping with the bone and recovery versus taking calcium on its own. There actually isn't great data on that alone being helpful, but yes, combining that with the other two can be.
Does Microbiome Labs have something with calcium in it?
Not right now.
Okay. K2, my recent M4K clinical trials shows bone density increase. Any plans to include MK4 in your product? Are you aware of any studies showing bone density increase with K2, MK7?
Yes. Yeah, I didn't present them here in the presentation, but yes, there are. And no, we are not looking at MK4 right now. Yeah.
Is this safe to dose when you have a VDR variant?
Yes, I take it, and I have VDR variants.
Okay. If you have gut absorption issues, would a sublingual liquid be better to take? Hi, Annette.
Depends on the extent. I've had some with like short bowel syndrome where I will do a sublingual, but that's a pretty extreme.
Okay.
But yeah.
Okay. Regarding all those factors of age, pigmentation, where one lives, and the rest, I've heard of certain apps that can best estimate how much vitamin D one should take. Do you trust one or two in particular? And if you could share what you love about those.
I don't.
Those apps at all?
No. I want to see the level. I want to see what your actual level is.
Okay. As someone who doesn't eat animal products, I'm just wondering what it is about the cholecalciferol that Microbiome Labs arrived at the form of vitamin D.
Because that's the most highly bioavailable form. Okay. Yeah.
What are your best food sources of vitamin D and K2?
Vitamin D, so that could be, mushrooms, salmon with the bones, if you eat the bones. K2, you said they also asked about K2. Yeah, there's not a lot of really of foods with vitamin D that are adequate. The majority is going to be your sun exposure. But for K2, I went over it in one of those slides, natto, fermented fish, putrefied fish meal. Yeah.
What are the clues that one should test for vitamin D receptor antibody? Oh my gosh, I just lost it. For the vitamin D receptor antibody, and if one tests positive, what does one do in such a scenario?
So various functional genetic testing will look at the VDR SNP, I think is what you're talking about, because we talked
I
about the
think
SNP.
so.
So there's several out there that you can do. I mean, if you have somebody who you're, or if you yourself are supplementing with decent levels of vitamin D and the D level is just not coming up, then that would trigger me to think that maybe we look at the genetics.
Jan, hi. I may have missed it. Did you talk about the MK7 versus MK9?
No, we did not talk about that.
Okay. Is there anything we should know?
Yeah, I mean, there's a few different MKs of when you're thinking about vitamin K2. So I believe there's like an MK6, there's an MK8. So it's just the various just different forms of it. So the big ones that have the most research are the MK4, MK7.
Are the organic acids tests that show the vitamins on them accurate or telling at all? Or should you not trust them at all and only trust the vitamin tested in your blood draw?
Yeah, I mean, oats testing can be a way of looking at any, all of your different metabolic functions and different nutrient levels. I'm not aware of one that's vitamin D specific or K2 specific because again, like I said, there's not really those are both fat soluble vitamins and there's really not a great way to look at that. But oats testing is great for, if you're looking for other, water soluble
Love
and
them.
yeah.
People love them.
Yeah.
Many Americans are overweight. Is there a rule of thumb where every 10 additional pounds outside the normal BMI level and we take X amount more IU of vitamin D in the same with vitamin K?
There are some equations, I can't think of them off the top of my head, but there are some equations that you can use when you're supplementing and starting to supplement in terms, and when you start supplementation, you want to check your vitamin, any sort of initial supplementation, you want to check your D level about 8 to 12 weeks after you start that initial supplementation, because then it'll tell you how your body's responding to it. So that's kind of the range there that you'd want to look at. So I'd say, you'd want to initiate and then check and then kind of see. But I believe there is, I just off the top of my head, I can't think of.
That's fine. Two more questions. Which natural foods and supplements could directly adversely impact vitamin D absorption assimilation? Would separating those out be okay in these cases? Cat here. Okay.
Yeah, I mean, there's not really, it's not like calcium and vitamin C and some of these other nutrients where there's going to be like food interaction issues really with vitamin D and K2. So
really grapefruit juice or whatever. Okay.
Yeah.
Does the vitamin D2 from mushrooms convert to D3 in the body? Heard some say that this is not, but it doesn't happen, but not sure.
Again, it would really depend on your kid. It could in theory, but I wouldn't want to rely on that. The research just shows that when you do K2, it just doesn't translate into increasing your D levels in the serum.
Okay. All right. Thank you. That was beautiful. You did it. That was in 1 hour and 1 minute. Thank you all so much for coming. Please grab the link and know that if you order by tonight, 8 p.m. Eastern, if you're here live with us, this is offered for those of you who are here live. Thank you for being here. Thanks for watching the replay as well. And that's just a different kind of, you're still getting 15% off. We love you for all of it. 15% off of everything at Microbiome Labs. The link is in the chat. And then if you do order by 8 p.m. tonight, you are going to get the slides from Alicia, and you are also going to get the vitamin D3K2, the calcium connection masterclass from Kiran Krishnan. So you send it to info@SIBO SOS, the proof of purchase. Please do send us proof of purchase. Don't make us be like, we're guessing whether or not you really did it. Okay, so just send us your proof of purchase because you've used our links, and by 8 p.m. tonight as well. And then, or shortly thereafter, we will send you the link. Sometimes my team who's just on different time zones. It takes a day or two. If you haven't heard from them with the reply back within like 2 days, feel free to nicely email us and we'll take good care of you. Okay. Thank you. That was amazing. Congratulations on your promotion to, hold on, Head of Scientific Affairs at Microbiome Labs. Big deal. Really big deal. Very excited for you and for them. And we're going to get some new speakers from you. Looking forward to that. And don't forget also that Serene Skin at Microbiome Labs is now available. Please put some love into the chat for Alicia. And if you're interested in that formulation for your skin, we are going to send out shortly, like in a couple of days, the replay of that particular webinar, so you can learn more about that, because it was excellent and it was not available when we did the webinar, but it is now. Okay, and we want. Thanks, everybody.
Thank you.
Thank you. We'll talk to you later. See you next time.
Bye.
Okay. Oh, chat's disabled, so they couldn't put the love in there. All right. I'm going to go ahead and open it up. She gets it, though. She feels love. She feels it. All right, Alicia. Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye. I'm just going to turn off the recording. Sorry about that. Thanks, everyone.